Hi there. My name is Todd Ellerin, and I'm head of infectious diseases at South Shore Health. And I'm also an associate physician at Brigham and Women's Hospital and instructor in medicine at Harvard Medical School. It's good to be with you today, and I'm going to present an ID board review. It's going to be case-based. These are my disclosures. Okay, so the first case is recurrent meningitis. It's a 55-year-old male with a past medical history significant for 2 episodes of aseptic meningitis over a decade before. He presents with 5-day history of headaches, diffuse muscle aches, chills, anorexia. There's no confusion. He's married with 2 children, monogamous. His exam's normal except for it has a low-grade temp at 100.6 Fahrenheit and mild neck stiffness. His head CT without contrast is normal. And you can see his LP. There's 267 white cells, roughly 80% lymphocytes, 56 red blood cells. The protein's elevated at 333, and the glucose is normal at 83. And here's an example of his CSF cytology. And you can see the lymphocytes on the differential, not surprising. He had about 80% lymphocytes, but these are very abnormal cells with this pale blue cytoplasm, very irregular, and this footprint-like nucleus here. What's the most likely diagnosis? A, recurrent enteroviral meningitis, perhaps Coxsackie or echovirus, the most common types of viral meningitis. B, recurrent bacterial meningitis from a parameningeal focus, like sinusitis or otitis or mastoiditis. C, a recurrent herpes simplex virus or HSV meningitis, or D, recurrent cryptococcal meningitis. And the correct answer here is recurrent HSV meningitis. If you were thinking this is viral meningitis because of the LP profile, the CSF showing a lymphocytic meningitis with a normal glucose, that would be correct. Bacterial meningitis typically gives you a low glucose and should be more polypredominant. When you have a parameningeal focus, there can be a mix of polys and lymphocytes. The glucose could be normal, but also in the history, we didn't hear about anything focal. And on his exam, there were no focal findings, as you might expect with a parameningeal focus. And recurrent cryptococcal meningitis, fungal meningitis, typically you see a lymphocytic predominance, which we saw, but it's often associated with a low glucose. And in his case, it was normal. So the correct answer here is HSV meningitis. And in fact, his CSF HSV PCR was positive, and that's how the diagnosis was made. Serologic testing, antibody testing, showed that he was negative for HSV1, but he had a positive HSV2 IgG, which we would expect in someone with a history of HSV infection. This recurrent HSV2 meningitis is referred to as Mollaret syndrome. So what are some of the key points about this take-home? So Mollaret syndrome is otherwise known as benign recurrent aseptic meningitis, which resolves without treatment. But most do treat with antiherpetics. Patients rarely report a history of HSV2 or genital herpes, although occasionally they do. But these patients are uniformly positive on HSV2 IgG. So if you don't have an LP where you can do CSF PCR testing on, you can test them serologically. We need to remind patients that although the meningitis is not contagious, they may be able to transmit the HSV2 to susceptible partners. This is can be considered an STI, especially with shedding and asymptomatic shedding. And chronic suppression with valacyclovir was studied, and it was a randomized controlled trial, but the valacyclovir group did not show any decrease in the number of recurrences of meningitis in that first year. And in fact, the patients that were in the valacyclovir arm of that trial and stopped it in year 2, they actually had a rebound and an increased number of episodes of meningitis. So while we may need to treat patients or place them on suppressive therapy to decrease transmission to others, the valacyclovir has not been shown to decrease recurrent meningitis. Next case. This is a 50-year-old female with 5 days of fevers, increasing confusions, and personality changes. The LP shows 350 white cells, 90% lymphocytes, and the glucose is normal. That LP is somewhat similar to our last case. The CSF gram stain and cultures are negative. What is the most likely diagnosis? I'll give you a second to think about it. And also, let's look at this MRI here. You have an MRI of the brain, and you can see increased signal. This is a T2 signal, increased signal in the medial temporal lobe here. And that's a clue to the diagnosis. And if you said HSV-1 encephalitis, you were correct. So what are some important aspects of HSV-1 encephalitis? As opposed to HSV-2 aseptic meningitis, which is not an emergency, HSV-1 encephalitis is a neurologic and infectious diseases emergency. You have to have a low threshold to do a lumbar puncture and institute early high-dose IVA cyclovir. Typically, we do 10 mg per kg every 8 hours. In neonates, we go up to 20 mg per kg every 8 hours. And that has been shown to improve outcomes. The earlier you start therapy, the better the outcomes. This can be a serious illness. It can have significant neurologic morbidity that can be permanent, and it can have mortality as well. The diagnosis is made by checking your CSF PCR for HSV-1. The sensitivity of that is extremely high, probably close to 98%. The MRI is often associated with temporal lobe increased signal on T2 weighted image and enhancement on T1 weighted image. That's very important. It's usually unilateral, but can be bilateral. And the EEG can show temporal lobe discharges. So these are some of the important diagnostics that are needed to make this diagnosis. But the most important thing is thinking about it. An early diagnosis and early treatment can be the difference between life and death with HSV-1 encephalitis. Next case, fever, headache, and blurred vision. This is a 20-year-old male who's previously healthy and presents with 2 weeks of fevers, headache, increasing neck stiffness, and double vision. He immigrated from India 9 months ago, and he lives in Austin, Texas, visiting family in Massachusetts. He was given BCG as a child. He had no sick contacts, exposure to animal or birds, recent travel. He's monogamous with his wife, and he's a business consultant. His exam showed that he had daily fevers as high as 101 Fahrenheit. And he had bilateral cranial 6 nerve palsies. He couldn't bury the whites of his eyes when he looked laterally on either side. His labs were normal except for he had a sodium of 127, so he was hyponatremic. His head CT without contrast was normal, and an LP showed 775 white cells. Again, mostly lymphocytes, but this time it was more of a mix, 56% lymphocytes, 37% polys. His protein was elevated at 169. His glucose was low at 19. That's the first time we're hearing about a low glucose here. And his opening pressure was elevated at 280 millimeters of water. What is the most likely cause of the subacute lymphocytic meningitis with a low glucose? I'll give you a second to think about this. And the correct answer here is C, tuberculosis or fungal meningitis. Remember, A, purulent bacterial meningitis should have a polypredominance, neutrophils. This case that I'm describing to you had a lymphocyte predominance one. Viral meningitis, well, that should give you a lymphocyte predominance, which he had, but the glucose should be normal. Tuberculosis or fungal meningitis, both of those are lymphocyte predominant and have a low glucose, so that would fit with this case. And Listeria monocytogenes meningitis, while that could give you absolutely a low glucose, and yes, it could give you a lymphocyte predominance, typically it's a polypredominance on the CSF, but the one major difference with this is that with Listeria, it should be more of an acute illness. You wouldn't have Listeria present over 2 weeks. Okay, this is the MRI. And you can see this is a pre-contrast image. And now on post-contrast, you can see here the leptomeninges are lighting up. And it's in the basilar part of the brain, really the brainstem. So this is what we call a basilar meningitis. And this is a different view that shows you the tentorium enhancing. The tentorium is what distinguishes the posterior fossa from the rest of the brain. And this shows you the differential diagnosis of a basilar meningitis. Neurosarcoidosis is on the differential. You can have carcinomatous meningitis from cancer, fungal meningitis, as we've mentioned already, tuberculous meningitis, which we've mentioned, and listeria meningitis. Listeria typically shows more micro abscesses, so really tends to look a little different. Now the results come in, and we have a lot of negative results. Bacterial cultures are all negative, as might be expected. His CSF cryptococcal antigen was negative, fungal culture is negative, VDRL for syphilis was negative, his HSV PCR was negative, tuberculosis PCR was negative, his CSF AFB cultures are negative at 4 weeks, his CSF cytology is normal, and his HIV antibody test on the serum was negative. Okay, now this is his chest CT showing soft tissue windows, and you can see here that there's lymphadenopathy in the mediastinum. All of this is abnormal. And this is abnormal lymphadenopathy as well, next to the carina. So a bronchoscopy revealed negative AFB smears and fungal cultures, and he had a mediastinoscopy, a biopsy which revealed non-necrotizing granulomas and fibrosis with special stains negative for AFB and fungi. No evidence of malignancy. So I'll ask again, and I know this is a challenging case, but what's the most likely diagnosis? Do we think this is tuberculous meningitis, fungal meningitis, or neurosarcoidosis? And the answer is tuberculous meningitis. Now, a lot of people think that this is neurosarcoidosis, so if you were thinking that, you are not alone. In fact, that was on my short list of my differential diagnosis when I was seeing the patient. But this was tuberculosis. And some important things to remember is that it's common in developing countries, but rare in the United States. It presents as subacute fevers with headache, with lymphocytic meningitis with a low CSF glucose. So that's an unusual finding. That subacute nature of the clinical course with the lymphocytic meningitis and a low CSF glucose is a real clue, very important, and not a lot of things do that. Paradoxical worsening of symptoms after initiating therapy may signify immune reconstitution. And no single test is 100% sensitive. The CSF AFB culture is the gold standard, but it may take up to 6 weeks to turn positive. In our case, it turned positive between weeks 5 and 6. The CSF TB PCR is insensitive. That's something that I learned from this case. You may assume that the PCR is very sensitive, but in cases of AFB PCR within the CSF, it is not. And the treatment of TB meningitis is with 4-drug therapy, the RIPE regimen, rifampin, INH, pyrazinamide, and ethambutol for 2 months, and then 2-drug therapy, INH and rifampin for 10 months. Of course, this assumes that you don't have drug-resistant virus. And you add corticosteroids if there's focal neurologic signs or mental status change. And in this case, we gave both the RIPE regimen and steroids at the same time. And that was empiric. So remember, there was a period of time when there were a number of people, in fact, some of the neurologists thought that this was going to be neurosarcoidosis and not tuberculosis. Next case, subacute headaches. A 45-year-old female notes 10 days of worsening headache and mild neck stiffness without photophobia. There were no fevers, no sick contacts. She was in her usual state of health until 4 weeks before, when she had a left popliteal fossa and back of the knee cellulitis, treated with cephalexin, which led to resolution in about a week. She was achier than normal, but attributed it to her workouts. Her CSF showed 100 white blood cells with 80% lymphs. The protein was mildly elevated at 60. The glucose was normal. The CSF gram stain was negative, and the CSF culture was negative. What's the most likely diagnosis and treatment? Give you a second to think about this. So this is an example of Lyme meningitis. The diagnosis was made by a serologic testing, which revealed a reactive Lyme strain and the Lyme IgM Western blot was positive. And the Lyme IgG may or may not be positive in these cases. The CSF Lyme antibody may be positive, and was in this case, and the CSF Lyme PCR may or may not be positive. I think some important features of this case with Lyme meningitis is to remember, again, it's a subacute meningitis. Most patients will present with over a week of symptoms, sometimes over 10 days of symptoms. And they may or may not describe a cellulitis, which is, of course, not cellulitis, but really the erythema migrans, that in some cases can look like cellulitis. And if it's treated with cephalexin, we know that that has no anti-Lyme activity. So these are patients that are often will come in. And in addition, some cases never present with the erythema migrans. So Lyme meningitis represents stage 2. This can be treated with either doxycycline or ceftriaxone. We used to treat this uniformly with ceftriaxone, but recent guidance has changed where you can actually treat now with doxycycline as long as they don't have signs or symptoms of encephalopathy. Next case, unexplained seizures. This is a 36-year-old male from Brazil who lives near Boston, history of one seizure 20 years before, and had a second witness seizure. He felt well before the seizure. No additional medical history, no alcohol, no illicit meds, and he's HIV negative. His labs were normal. And this is showing a CT, his CT, and you can see here a punctate area of calcification. And this is an MRI, and it actually shows calcification with edema surrounding it. What's the most likely diagnosis? Do we think this is tuberculous meningitis, a calcified meningioma, neuroschistosomiasis, a cryptococcus coma in an immunocompetent patient, or neurocysticercosis? And I'll give you a second to think about this. And for those of you who thought this was neurocysticercosis, you're right on. Some fast facts about neurocysticercosis: it's the most common cause of seizures worldwide. And the triad of seizures, being from a Latin American country, and intracranial calcifications puts your suspicion for neurocysticercosis extremely high on the list. We treat calcifications with anti-seizure medications. We treat cysts that are live or degenerating with albendazole and steroids, okay? Because our patient had calcifications but no live or degenerating cysts, we only treated him with anti-seizure medications. An ophthalmologic exam is crucial prior to treatment to rule out any retinal lesions that could be made worse by the treatment. Next case, a bumpy hand. This is a 55-year-old male with no significant past medical history who slammed his hand in a drawer and developed this nodular rash a couple of weeks later. He's not a gardener. He has 2 pets named Sushi and Bubbles. What's the diagnosis? And here's his hand, and you can see here, this is a nodule, not particularly tender when you press on it, but you know that there's depth. And this is another nodule. And notice, the skin in between is completely normal. So this is not your typical run-of-the-mill streptococcal cellulitis. So one of the clues to what the diagnosis is if you can figure out what his pet Sushi and Bubbles are, what type of animals they are. We think they're dogs, we think they're cats, or something else. And if you're thinking that these aren't dogs or cats, you may be right on target. The answer to this is Mycobacterium marinum. And here's some fast facts about this. It's a major cause of nodular lymphangitis, along with sporothrix, which we call sporotrichosis, and nocardia. If we go back for a second here, the other name for this is a sporotrichoid spread. This nodular lymphangitis, as you have nodules going up the arm following the lymph channels. You need to ask your patient whether they own a fish tank. That's really important. That's the key way to make this diagnosis. It's very common. Or they could be a fisherman, but oftentimes they have some intersection with their own life and fish. And another name for this M. marinum infection is fish tank granuloma. That's how common these patients who own fish tanks can get this. And it's called granuloma because when you biopsy these lesions and get a deeper biopsy, you see granulomatous dermatitis or granulomatous inflammation. You can see non-caseating or caseating granulomas. Antecedent trauma is a risk factor. Remember, it's not just the cleaning of the fish tank, because when our skin's intact, then we're not at high risk. But if you have an abrasion on your skin, like our patient did, or trauma to the skin, and then stick your hand in the water, remember the Mycobacterium marinum is there. It's the fact that our skin, when our skin is not intact, that's a major host defense that gets violated, and you know that's an issue and sets you up for infection. We often treat with clarithromycin, which is Biaxin, and ethambutol, which is Myambutol, and oftentimes you only need 2 drugs. I'll occasionally add rifampin if it's more severe or not responding to these 2 medications. And we often treat for a minimum of 3 to 4 months. And as I mentioned before, the biopsy often shows these granulomas. Next slide. This is an image. So you can see this person is asymptomatic, but had this rash lesion at the side of the tongue. You try to scrape it off, but it wouldn't come off. And there's the other side. So it's bilateral. What's the diagnosis and the cause? So if you said oral hairy leukoplakia, you're correct. And the underlying cause of oral hairy leukoplakia is EBV, Epstein-Barr virus. But what's even more important, and this is key, if you thought that he was immunocompromised and had HIV or AIDS, you're spot on. His HIV test was positive. So oral hairy leukoplakia, especially in someone with risk factors for HIV, you want to make sure they ask about the risk factors, and no matter what comes out of that, you still want to do mandatory HIV testing to make sure that this person doesn't have HIV. This is just an example of one of the cutaneous stigmata or dermatologic signs of HIV. Rash after travel. This is a 30-year-old female who traveled to Brazil 3 months before, traveled to St. John's Island 10 days before, and spent 5 days there and felt well. 2 days after returning home, she developed a headache at the level of her eyes and a mild sore throat and an itchy rash that started on her face and spread down her chest and her abdomen. She wasn't particularly achy. She didn't have any conjunctivitis. The labs were normal, except she had a white blood cell count that was ever so slightly low at 4,000, right at the lower limit of normal. And here's a picture of, you can see her face, and you can see that she had this itchy rash on her face. And then when you look at her palate, you can see these petechiae there. And this is her chest, and you can see again, pretty faint rash, itchy. Her abdomen, again, pretty subtle, but present. Nothing that looked specific about this. And then she had these interesting other type of rash where you could see these little pinpoint little bumps with a little halo of clear and then kind of bruising around them. And again, these were itchy. How do we put this together? Well, what's the most likely diagnosis? Do we think this is measles, given the craniocaudal spread of the rash? Do we think this is dengue fever? Do we think this is chikungunya? Or do we think this is Zika? And here are the results. The dengue IgM and IgG were negative. The chikungunya serology, negative. And the Zika serology, negative. So what's the diagnosis? And if you said Zika, you're correct. But I just want to go back here for a second and think about the different possibilities of this rash. So what about measles? Well, I didn't show you her eyes, but I did tell you that there was no conjunctivitis. That's important. And there was no coryzal symptoms, cold-like symptoms. Okay, she didn't have high fevers, all right? She didn't have Koplik spots. These would not be Koplik spots. Koplik spots are typically in the buccal mucosa, in the inner cheek. Okay, that's where those are. These are petechiae. So remember, even though the cranial to caudal spread of the rash may make you think of measles, there are other viruses that can do it as well. We've seen cases at the Brigham, actually, of enterovirus mimicking measles. Now, when you're thinking of between dengue, chikungunya, and Zika, these can all do pretty much very similar things. I think Zika tends to be milder with the clinical symptoms, where dengue and chikungunya can be more severe. Dengue tends to give you more myalgias, where chikungunya can give you more arthralgias or arthritis. But again, we think of these as a bundle. When you're thinking of dengue, you need to think of Zika. When you're thinking of chikungunya, you need to think of Zika. So here's some facts about Zika. The Zika IgM is less sensitive in that first week after infection. It becomes positive more in that second week. The Zika PCR of this, both the serum and urine, are more sensitive early on, and her blood and her urine were both positive by PCR. So if you only sent the Zika antibodies, we would have missed this diagnosis. Conjunctivitis has been observed in Zika, but was not present in this case. The incubation period is under 2 weeks. And of course, most importantly, and I know you are thinking this, we need to know if she's pregnant. Because with Zika, we know that there's problems with congenital anomalies. Okay, you can have problems with microcephaly and other neurologic problems as well. It can be severe. Fortunately, the prevalence overall of Zika and the incidence has gone down significantly. Last case. This is a 65-year-old male with diabetes, hypertension, and coronary artery disease. He presents in April of this year, 2020, with a dry cough and worsening shortness of breath. No pharyngitis, aches, sore throat, or loss of smell or taste. He was afebrile on admission. His O2 sat was 90% on Romair, so that was low. It improved to 94% on 2 liters by nasal cannula. His exam showed scattered rales in the lung, and he had a faint purplish reticular rash, mostly on his knees and lower thighs. His inflammatory markers were elevated. His CRP was 120, his ferritin was 2100, and his procalcitonin was low at 0.12. His chest had bilateral multifocal ground glass opacities. His respiratory viral panel, NP swab, was negative for influenza, parainfluenza, RSV, adenovirus, the common coronaviruses, and human metapneumovirus. His NP swab was for SARS-CoV-2 was negative ×2. He had worsening hypoxemia despite being prone and put in the lateral recumbent position. And he was placed on a non-rebreather and high flow oxygen. And ultimately, he deteriorated and required mechanical ventilation over the next week. This is an example of his chest CT. You can see multifocal ground glass opacities, and there is a peripheral nature to this as well. And it's bilateral. And this shows you very faint, kind of non-impressive, but reticular purplish rash. So what's the diagnosis? How is it made, and what's the treatment? Do we think this is COVID-19? The diagnosis was made through serologic testing, and he was placed on hydroxychloroquine and azithromycin. B, COVID-19. We did an endotracheal aspirate for SARS-CoV-2 on PCR, started remdesivir and convalescent plasma. We think this was C, COVID-19. We did an endotracheal aspirate for SARS-CoV-2 PCR, but started him on remdesivir and dexamethasone. Or D, that this is COVID-19. We did an endotracheal aspirate for SARS-CoV-2 PCR and started him on remdesivir and tocilizumab, which is the IL-6 receptor antagonist. And if you said C, I think that's the best answer right now, and that's what we did. So some fast facts on COVID-19. I'm sure you have your own dedicated lecture on this. But remdesivir has been shown in at least in one randomized controlled trial to hasten clinical recovery by about 4 days, but did not have a statistically significant mortality benefit. We're still waiting for more data to be presented on this and to understand more about what role remdesivir plays. But so far, as of the time of this recording, remdesivir is considered, at least in the US, to be part of the standard of care for treatment of COVID-19 patients who are inpatients hospitalized. And dexamethasone has been shown in one large randomized controlled trial. It was open label, called the recovery trial, to decrease mortality in hospitalized patients with COVID-19 who are on supplemental oxygen by 20%, and in mechanically ventilated patients by approximately 33%. But also, and importantly, led to a non-statistical increase in mortality in patients with COVID-19 who did not require supplemental oxygen. So in the mildest patients, we want to make sure we are not giving dexamethasone. But in the sicker patients who require oxygen, this is an important part of the therapy at this time. Also remember, the sensitivity of the NP swab, the nasopharyngeal swab for patients with COVID-19, depends on many factors. Swab technique, time since onset of symptoms, the viral load in the nasopharynx, and the presence of symptoms. In some studies, it may be as low as 70%. So a negative nasal swab does not mean that your patient doesn't have COVID-19. And I think this case was a good example of this. In patients with typical symptoms of COVID-19 who have serial negative NP swabs, or even a single negative NP swab, but it has a chest CT with typical findings, multifocal ground glass opacities with a tendency for peripheral involvement and no pleural effusions, the sensitivity of sputum and endotracheal aspirate is higher than nasopharyngeal and oropharyngeal swabs, and this has been shown in studies to date. So with that, I want to thank you very much for your attention.